Welcome to CivilNet. My guest is Dr. George Melikian. He's a doctor in Los Angeles and specializes in infectious diseases, notably in HIV/AIDS healthcare. He spent weeks in Armenian hospitals to help patients infected by coronavirus during the 2020 Artsakh War. Thank you for joining us, Dr. Melikian. So you spent, as I said, time in Armenia during the war helping to treat patients with COVID-19. What was the situation in the hospitals like, and how would you describe it? Were there patients who were at the same time wounded because of the war and infected by the coronavirus?
So when I was here in October, I spent time in two categories of hospitals, both the COVID hospitals and the hospitals where wounded soldiers were being taken care of. The patients in the COVID hospitals were different than, meaning there weren't really soldiers in the COVID hospitals. And that's consistent with COVID because COVID rarely causes younger folk to become sick enough to go to the hospital. So in the COVID hospitals, what I was involved with was, yes, correct, helping, treating COVID patients. And it was a very dire situation at the time. There were no empty beds. There were patients who were sleeping on the floor in the waiting room. The biggest challenge I would, if you were to ask, would be getting enough oxygen to patients who were, desaturating, or oxygen saturation was low, not compatible with life, and getting them oxygen.
But you also were in a hospital where soldiers were wounded. And
correct.
So what about the situation there? How was it?
There, what I was helping out with was because I'm an infectious disease specialist, was really helping out with wound infections. There's a lot of these wounds where the soldiers would come in with were obviously open wounds, bone exposure, and dirt, and whatever else is in the environment. And these wounds very quickly become infected. Anytime a bone is exposed actually to open air, if you could see a bone, that's basically considered a bone infection in our field, because that's how it basically works. So here the issue was which antibiotics to use, which are the best choices and best regimens, and given the injuries that we were seeing at the time. Mm-hmm. And then I'm back now for the third wave, the rates have been going up. So this is the second time coming this time I'm mostly working with COVID, but also again with wounded as well. A lot of the battle infections, the bone infections I was talking about, there's an early infection that happens, like right at the time when there's injury. And then there's a second wave of infections that we usually see that come about 2-3 months down the road. These are related to, when you have fixators, when you have metal rods, plates for long-term fixing of injuries or broken bones, and then these can become infected late, and that's it, because the bone infections are slow and they show later. So
you just talked about the oxygen saturation. So I had a question related to the situation in the hospitals. As you said, you mentioned that we were in the third wave of the COVID-19. And the number of daily deaths has grown in Armenia. What would you say about that? Are the Armenian doctors dealing decently with the virus? Are they coping well, or there is something lacking, or there's something that they should do better? What are your observations so far?
The doctors that I've worked with on the inpatient side in the hospitals, I have to say I'm very impressed in the sense that they're actually using the same protocols that we are in the States. The COVID isn't very complicated to treat, just because there really isn't that many things on the plate as with other types of infections. There's multiple avenues. It really comes down to anticoagulating, thinning the blood to prevent clots, providing steroids that will help lower the risk of that's what really, I should finish my sentence, that lowers the risk of this called cytokine storm. That's really what the respiratory symptoms are. It's an inflammatory, it's your own body with this inflammatory storm that's attacking itself. And that's what ends up killing most people, and the steroids helps soften that. And number 3, which is plus minus, is an antiviral agent, such as remdesivir, which we have here. The data on remdesivir isn't particularly strong. It's harmless, though. We use it as standard of care, but I can't tell you that it's, very, 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 very effective. We use it. And of course, lastly, the most important thing is oxygenation, getting the patient through this critical period, this cytokine storm that I was talking about, by providing them with enough both concentration of oxygen and the flow, the pressure, or that the oxygenation is being delivered. Generally, if you ask me, everything, all the other points, except for the oxygenation, are well covered. They're doing a great job. And I wouldn't blame this on the physicians personally. It's just the infrastructure it's very difficult. So they have oxygen machines, but the amount of flow that's provided is still very limited. We're looking at 10 liters, maybe in some cases 20 liters. In the States, we use 60 liters of flow to get patients through it. And again, it's a bit of a waiting game with coronavirus, meaning you provide these medications, you provide the oxygen, and you give it time and hope that the patients, most of them, will come out of the storm and do okay. But if you can't get enough oxygen to them during that period, then they'll succumb. One thing I wanted to mention that is, I think, a good way to look at a broader picture of how Armenia is doing, which was your question, how are we doing, is if you look at the epi curves for the number of cases and number of deaths per day, and you'll see we're talking about the third wave, you'll see 3 peaks for both of those, for both the number of new cases and both the number of deaths. The thing that is very striking is if you put these curves on top of one another, in Armenia they overlap completely. And you can try this yourself. You'll see the deaths and the cases, the peaks of those curves are exactly in the same spot. And what we really should be seeing is there should be a shift to the right for the deaths, meaning you have a peak in the number of cases, and then the peak in the deaths should follow sometime later. Of course, they're much less than the number of deaths is much less than the number of cases, but there should be a little bit of a gap because people don't basically get diagnosed and die that quickly. Seeing that they're overlapping tells us something about what's going on, which needs to be parsed a little bit further, but roughly it can be divided into, separated into the effects of either and or late diagnosis and treatment failure. Mm-hmm. These are the two things that would cause these curves to overlap. And by late diagnosis, meaning, what it is having symptoms, but waiting until it's too late, until you're really, really sick, until you show up at the hospital or get tested, which is not recommended, obviously. And number 2 is what we're talking about with oxygen.
But okay, so the problem is the late diagnosis and oxygen. I guess you, as a doctor who's underground, who's here for this reason, you talked with the doctors. You told them how you do in the U.S. and how they should do to avoid more deaths. What do they say to you? Do they listen, or do they explain what the problem is so that they can do that? Where's the problem that creates this situation and that does not, why don't they decide to do what you say, for example?
No, they are.
The oxygen, for example. What's the issue with the oxygen?
The oxygen is an infrastructure issue. It's not somebody, saying, "Well, I'm going to turn down the oxygen." Or they have it set on maximum, but generating that kind of oxygen, the infrastructure, the machinery, isn't there. We are working on that. There's different ways of changing that, helping that. There's different valves to use. That can increase the pressure, but those also can come at the cost of lower oxygenation concentration, but it will give more pressure, which is also helpful because it opens up, when you add positive pressure into the lungs, it opens up the airways to allow, if they're collapsed, to allow for absorption of more oxygen. But this is a infrastructure level issue, and it's it's very difficult. And I got to say, to be very balanced, on the other side of that equation, what we just had, one of the hospitals where I was at, they said they were the COVID hospital was closed for almost a week after the second wave, and then it opened up again. So making these types of enormous investments too, we don't know what the COVID situation will be 2-3 months from now. And these machines we're talking $700,000-$800,000 machines, which they, by the way, did install new machines over the December time period, both this hospital and also at the main generator hospital where the oxygen is produced. So the oxygen is delivered both made in the hospital, and it's also generated centrally and transported there in big tanks. But what I was saying is on the other side of the equation, there is the issue of spending very large amounts of money for something that may not be a problem in a month. Not to say that nothing should be done. It's just these are some of the hurdles.
So let's talk about the vaccines. In Armenia, there are suspicions towards vaccines, specifically towards the AstraZeneca because of its effectiveness, efficacy, and because of some cases of thrombosis and other deaths. And so people are more suspicious about this vaccine. First, could you please explain to us what's the difference between effectiveness of a vaccine and efficacy of the vaccine so we understand clearly? And what can you say about these vaccines and about AstraZeneca in particular?
So what we really measure is the efficacy of the vaccine. And that is basically the percentage compared to people who are not vaccinated, the percentage of people who are vaccinated and the amount or the risk of becoming infected with the vaccine in place. So we use numbers in percentages from 0 to 100%. So for example, a 90% effective vaccine will essentially protect 90% of people with the vaccine will not be infected or immune from infection. I cannot stress enough the most important issue here is getting vaccinated. There's been a lot of hype. There's been a lot of hype in the media about some of these side effects that have happened. And I can give you very exact numbers. For the AstraZeneca vaccine, in Europe, there were 5 million exposures to that vaccine. This is concrete data that we have. And among the 5 million doses, there were 30 cases of thromboembolic, not 30 deaths, but 30 cases of thromboembolic events or blood clots. Now, obviously that's not zero, but 30 out of 5 million is 0.0006, if I'm not mistaken, %, which is significantly less than the risk of dying from COVID, especially we're a small country and that the rates that COVID is transmitting itself through this population. I cannot stress enough how important it is to get vaccinated. Now, the efficacy of the vaccine is somewhere around 80-85% is what these numbers are. But this is important to keep in mind. There's unmeasured, or I should say unmeasured, but this is just a strict efficacy figure that we're seeing. What we also know is people who get vaccinated, they may get infected, but the chance of them having a bad outcome, meaning winding up in the hospital or dying, is exceedingly small. We're talking 99% without, meaning 99% do not need hospitalization. So they may still get infected, but they will have a very mild course of illness. So when somebody sees a number that says, okay, it's 80% effective, that means there's a 20% chance. But it's 20% chance of being infected, but it's not 20% chance the same as you would be infected and having the risk of dying. So it's very protective. And also the second thing to think about is being vaccinated has secondary effects. It not only protects you, it protects those around you because you can no longer transmit that virus. There is some speculation in the community, in the States at least. Well, we don't have definite studies showing that people who are infected are not transmitting the virus. I mean, vaccinated people. That would mean somebody is vaccinated and they get sick, but they're asymptomatic. They have no symptoms, but they're shedding the virus. That's the question. In fact, and by the way, let me add one more thing. That's not something that any vaccine trial looks for. It's not part of any vaccine protocol, even the influenza vaccine or whatever vaccine. We don't look at asymptomatic transmission. It's become an issue because people have raised it on this for coronavirus. And I could tell you, AstraZeneca, in fact, is the only vaccine trial, compared to Pfizer, Moderna, J&J, where they actually, within their protocol, they did check those. They did PCR tests on people who were asymptomatic, who were enrolled in the trial. The other trials didn't do that. And this is for the reason to see, okay, if you're not symptomatic, are you infected? In the other trials, only if somebody got sick would they do that. And AstraZeneca did not find people who were vaccinated were shedding the virus. So that's very good news. That's if there's a little bit of a myth around that, and I'm sure there'll be more definitive data to support that, but it's not surprising. And we see that effect on an epidemiologic level. So to complete this thought, though, about the benefits of vaccination, again, I cannot stress how important it is and how small the risk is for having bad side effects with getting the vaccine. Most people will have 1 or 2 days of fevers, or they may not feel well, feel weak. That's completely normal, and that goes away. I had it too when I got vaccinated. That actually means the vaccine is working. But beyond that, it's absolutely safe. Nothing is completely 100% safe, but comparatively, I would vaccinate myself and my immediate family without question with the AstraZeneca vaccine.
But no vaccine is 100% sure plus. I mean,
Correct.
There's no vaccine even for the flu or any.
No, the flu vaccines are almost a shot in the dark because we don't know what the predominant strain is going to be when we design buoys, and when the CDC designs the flu vaccine every year, they do it by forecasting, thinking what the predominant strain is going to be. And we don't have that problem with coronavirus. And by the way, the vaccines are effective against all the strains out there. There's no evidence that any strain has been completely around it. Some slightly less than others, but it's completely effective.
In the vaccine field, there's been talk about COVID vaccines technology that could be used to target HIV, sickle cell, and cancer. Both COVID-19 vaccines, Pfizer, BioNTech, and Mrna use something called messenger RNA, mRNA, to send genetic instruction to the body's cells that result in them producing antibodies for the coronavirus without the virus actually being introduced to their body. So this is what they might have discovered, and that might work on other, as I said, sickle cell, cancer, and HIV. Could you tell us more about that? Explain us what's all this about, and are there good chances that these vaccines could be efficient for other diseases?
Sure. So mRNA vaccines, even though this is the first grand rollout of an mRNA vaccine, this technology has been around for about 10, 15 years. Essentially, you are able to synthesize a sequence of mRNA that is designed specifically what this sequence is, and you can, with that, transcribe that into a protein. So you work backwards. This is what they have done. You look at the virus, you look at whatever you want to target. In this case, it's the spike protein, and you work backwards, and you design a specific mRNA sequence that will produce whatever it is that let's just, in this case, it's the spike protein. This mRNA is then injected into your body, where your body, your immune system, recognizes it as foreign. So then it makes antibodies against it. And so instead of having to inject pieces of the virus, or even a live but ineffective virus, which is a traditional way of making vaccines, what you're introducing there's no life involved at all. It's just a sequence of mRNA that the body recognizes. The reason this is very promising for HIV and cancer is because the immune system is involved, believe it or not, in cancer and obviously in HIV. So you were able to produce something very, very specific that designer made for a specific epitope, for a specific region, that, for example, that remains constant. With HIV, traditionally, I mean, when working on vaccines, we use pieces of the HIV virus or viral vectors, but we weren't able to specifically target a part of that virus for the immune system to attack, because the virus itself is changing very rapidly, a lot of the virus. So the benefit with mRNA vaccines is we know the structure of the virus. You could target a region, for example, a structural protein. It's called scaffolding, for example, which is a framework, like in the building, the framework of the building, the framework of the virus, something very specific and unchanging, and develop a vaccine based on the mRNA in that region, which could be very effective. That's what the promise holds. And it's something that I think we'll see a lot more of. And just for instance, I mean, look how quickly we were able to produce mRNA vaccines for coronavirus in a very short amount of time because of this technology. If I may, I apologize. I may add one more thing I forgot to say about the vaccination issue. The most important thing is to get those who are at highest risk vaccinated first. So again, those aged 55 and over, and those with chronic conditions, heart conditions, high blood pressure, diabetes, and obesity. If we could just prioritize, and we're a small country, so it's not that we have so many people to worry about. It's a small group of people. But once we vaccinate, or this high-risk population is vaccinated, I think we're 80% there for beating this pandemic in Armenia.
Thank you for this talk. Thank you for watching, and continue to follow CivilNet.